welcome to Osteobites. Thanks so much for taking the time to join us today. We'll give a couple seconds here as everyone enters and gets settled into our virtual room. We are so excited, and again, thank you for joining us for our first episode of Osteobites Season 5. My name is Christina Iptoma, and I am mom to Osteoangel Dylan and Director of Scientific Programs for MIB Agents. And today on Osteobites, we are joined by a terrific team. We have Dr. Keri Schadler of MD Anderson Cancer Center and Dr. Kiri Ness from St. Jude Children's Research Hospital. And they will provide a clinical perspective as well as an overview of the latest evidence that documents the need for and the initial success of exercise intervention during and after treatment for cancer. Thank you so much, Dr. Schadler and Dr. Ness, for joining us on Osteobites today. We are thrilled to have you. Thank you also to our panelists, Walker and Vicki, for joining us today. And I have to say, this episode has been really long in the making. It was actually Vicki's suggestion as a topic for Osteobites. And I'm so excited that we really have kind of the foremost experts on this topic joining us today. So I'm very excited for this episode. A little bit more about our guest today. Dr. Schadler is an associate professor in the Department of Pediatrics at MD Anderson Cancer Center. Her lab utilizes mouse models and collaborations with clinical investigators to delineate the multifaceted effects of exercise on the tumor microenvironment. Specifically, the Schadler lab aims to understand how exercise changes cellular and molecular signaling within the tumor vasculature and immune cells, and to use exercise as a tool to enhance tumor response to standard therapies. And Dr. Ness is a physical therapist and clinical epidemiologist whose research focuses on the late effects of childhood and adolescent cancer and its treatment. She has a particular interest in human movement and performance, designing interventions to prevent functional loss during therapy or remediate impairment following curative treatment. She has over 350 peer-reviewed original research papers and has continuous funding to support her work since 2005. She is the MPI of the St. Jude Lifetime Cohort and PI of the Human Performance Laboratory at St. Jude Children's Research Hospital. Thank you both so much for joining us today. And we just have a few announcements and reminders before we get started. January is a jam-packed month at MIB. We have several opportunities and deadlines this month. For our scientific community in the US, there's still time to apply for our Outsmarting Osteosarcoma Research Grant. There's a $100,000 one-year grant and a YI $50,000 grant. And we are going to have multiple awards this year. Our application is relatively short, so you still have time to apply. The due date is January 26th, and the application is on Proposal Central. And I will put some links in the chat on where you can kind of find all the stuff that I'm going to be talking about. Also for our scientific community, abstracts for our annual FAPTA conference are due January 12th. That's tomorrow. FAPTA is going to be June 20th to 22nd in Cleveland this year. And if you haven't been, it's an incredible experience that brings together the entire osteosarcoma community, clinicians, researchers, patients, caregivers, advocates, industry. We also have a limited number of FAPTA travel awards for medical professionals. The application is open now, and applications are due in March. So you have a little bit more time for that. Also, for any osteo warriors or siblings 15 to 22 years old, please consider applying for our 2024 Junior Advisory Board. It is a wonderful and empowering way to connect with other patients, engage in patient advocacy, and have your voice heard and make an impact. In addition to helping build current programs and design future programs to meet the unique needs of osteosarcoma warriors and families, JAB members also participate in the Childhood Cancer Alliance Action Days in Washington, D.C. They represent patient voice in different industry and academic patient panels, and they also have volunteer and speaking opportunities at our FAPTA conference. Monthly meetings are held via conference call, and then also there is an in-person meeting at our FAPTA conference. Those applications are due January 23rd, so we have a little bit of time for that. And then lastly, there's no deadline to register for this one. This is whenever you need it. In addition to our weekly Healing Hearts group sessions for bereaved osteosarcoma parents, which are on Wednesdays at 7 p.m. Eastern, we are adding a Healing Hearts Wellness Workshop on the last Wednesday of each month at 7 p.m. Eastern. These are led by the amazing grief coach, Lori Krause, and they're open to parents and siblings. And in these workshops, you'll learn techniques that can allow you to better manage stress, moods, and feel more grounded in your life, and also learn new practices that help to stay healthy, embrace new experiences, and thrive while living with loss and grief. So lots going on. I will put some information in the chat about that. And then Walker, can you go ahead and introduce yourself, please?
Yeah, hi, my name's Walker, and I'm an osteo warrior and this year's Junior Advisory Board Vice President. I was diagnosed in 2018 and had a knee replacement in my left knee, so I'm really excited to hear more about today's presentation. And from there, I'll hand it off to this year's Junior Advisory Board President, Vicky.
Yeah, so hi everyone. My name is Vicky Hoy. I'm also an osteo warrior and currently the Junior Advisory Board President, but Walker and I are only those titles for one more month and then we'll be handing off. But I remember asking Christina for this episode many months ago, so I'm incredibly grateful to see everything play out. And on to you, Dr. Schadler.
Right. Well, thank you so much for the opportunity to be here. I'm just getting my screen share going. Okay. So my lab actually is relatively preclinical in our focus, which means we use a lot of mouse models to try to understand how exercise impacts the tumor itself and what that might mean for therapeutic response. And so we've done quite a lot of this work in a variety of models of cancer types. So I'm going to show you some pancreatic cancer, some melanoma, some Ewing sarcoma. And what you're going to notice is that unfortunately, we don't yet have data from models of osteosarcoma, but I am actively working with Dr. Ness, who will be presenting right after I am, to get the funding to check this whole idea out in patients and hopefully mice with osteosarcoma. So with that, I'm going to give you sort of the overview. Give me 1 second. My slides are frozen. There we go. Okay. Oh. Well, there wasn't supposed to be this big white square covering this slide. This was actually a statement from the American College of Sports Medicine where they basically convened a group of experts to look at what do we know about exercise for patients undergoing treatment for cancer or who are survivors of cancer. And they found that there are so many reasons that exercise really should be incorporated as a part of your life, both during and after treatment. I mean, those were things like reducing fatigue and improving physical function and quality of life. And all of that is under the expertise of Dr. Ness, who will present next. But before she goes, I'm going to talk to you more about what does exercise actually do to the tumor and what does it do to therapeutic efficacy. So these models really represent what happens if you exercise while undergoing treatment. And so to do that, we do mostly models of mice. So we literally have treadmills that we put the mice on and make them perform exercise. But we also collaborate quite a bit with our clinical colleagues to look at whether what we find in mice is true in patients. And so we look at the tumor and not just the tumor cells, so not just the cancer cells, but the microenvironment, which would include the blood vessels, the immune cells, the supporting fibroblasts. And we look at them at a cellular level as well as a molecular level so that we can really understand what is exercise doing and how can we make smart choices about the type of exercise, the intensity of exercise, and the timing of exercise relative to things like standard chemotherapy. And so I'm going to start with talking about what exercise does to blood vessels because that's what we have studied for the longest and have the most information on. And so you may or may not know that in most solid tumors, only about 50% of the blood vessels in the tumor itself are actually carrying blood. And so if you think about the fact that most chemotherapies are given IV, which means it needs to get there through a blood vessel, that's a little bit of a problem for drug delivery. And so what you're looking at here is a Ewing sarcoma that was grown in a mouse. And then right before euthanizing the mouse, we injected with a blue dye. And the blue dye is just to represent chemotherapy. So all of this is a tumor under the microscope. The blood vessels are in green. But as you can see, the blue dye, which represents chemotherapy, only went to parts of the tumor, whereas other parts of the tumor, although there are some green blood vessels, did not get any dye. And so if this was chemotherapy, that would be a region of the tumor that didn't get any chemotherapy. And so really, we need to think about how can we make these blood vessels work as well as these blood vessels so that the chemo gets everywhere. And so in thinking about that, there are lots of historical examples of trying to do that therapeutically, so using drugs. But I was really interested in doing it using exercise. So exercise is very well known to improve blood vessel function and health in normal organs of your body. And so we thought that perhaps what we could do was start with these tumor blood vessels, which are very dysfunctional, right? So they cause hypoxia, not enough oxygen in the tumor. They cause sporadic drug delivery. They cause poor immune cell access, so it's hard for immune cells to target the tumor. And we thought that we could use exercise to promote more functional blood vessels in the tumor itself. This will deliver blood more effectively, oxygen more effectively, most importantly, drugs and immune cells more effectively. And so to ask whether this would really work, we used this very simple model. We have treadmills that our mice can go on. We give the mice a tumor. We basically inject the tumor into the mouse. We wait for it to establish that you have a fully established tumor. And then we treat them in 4 ways. Either they're a control, they get nothing, or they get doxorubicin or another appropriate chemotherapy, or they get exercise, or we combine where they exercise 5 days a week at 45 minutes a day at a moderate intensity that's roughly a brisk walk or sort of you're a little bit out of breath but not gasping in any way, so that level of intensity. And then we give them chemotherapy 2 or 3 days a week depending on the chemo. And so we used this model and we first looked at what happened to the blood vessels in the tumor itself. Okay, so what you're looking at are 2 types of tumors, pancreatic tumors or melanoma. On the left are the non-exercise tumors, and on the right are the exercise tumors. So the blue are tumor cells, and the green are blood vessels. And what I hope you kind of can see is that in tumors from a non-exercise mouse, the blood vessels are there, but they look sort of disconnected, unorganized. You can't really see, like, where would blood flow through these pieces of vessels. After exercise, what you get is this opening of the blood vessels. So you get elongated blood vessels. They now look more mature, like a functional blood vessel would, and you now have more of these open lumens. And so we see this in several tumor types. I'm showing you 2 examples here. And it's not just does it look different, but we can actually quantify this. So how many open lumens are there? How long is the average blood vessel, which indicates perhaps maturity of the blood vessel function. And what we see is that comparing tumors from exercised mice to non-exercise, you get this really significant improvement in the structure of the blood vessels. But of course, changing the structure is not exciting if we don't change the function, because it's function that will improve the drug delivery. And so we have a couple of ways to look at tumor blood vessel function. What you're looking at here are tumors from mice that either did not exercise or did exercise under a microscope. But before we euthanized the mouse, we injected them with something called lectin. So it's labeled with a red dye. And it basically, any blood vessel that it flows through, it just sticks to the walls and causes it to turn red. So what you can do is you can look at all of the blood vessels here in green and then compare that to how many of them got labeled by the red dye, which tells us whether it was functional. So here we've quantified how many functional blood vessels in tumors from non-exercised mice, roughly 50%, which is consistent with the literature and with what we know about tumors in patients. After exercise, I hope that you can see there's a lot more of this red label, which means a lot more of this functional blood vessels. So now you're closer to about 75% of the blood vessels are functional. So again, the idea is that more functional vessels will improve the drug delivery to the tumors. And so one really key aspect for drug delivery, oops, I went the wrong direction, is permeability of the vessels. So in healthy blood vessels in most of your body, the ability of any liquid, blood, and whatever drug is in the blood to leak out of the vessel is regulated tightly by how the cells form these junctions, right? So they should be pretty tight, and it should be tightly regulated what can leak out into the organ. In the case of a tumor, what happens is that you get really big gaps in the blood vessels, which causes inappropriately high permeability. So what we've done here is we injected mice that were bearing Ewing sarcoma tumors. We injected them with these very large green molecules. And if the blood vessels are appropriately permeable, it should not leak out. So you should not see green. Here in the mice that did not exercise, these are again tumor cells in blue, blood vessel in red, inappropriate leakage shown by green. You see lots and lots of inappropriate leakage. But in the tumors from the exercised mice, significantly less of this inappropriate leakage. And so you might be thinking, okay, but we want leakage because we want the drug to leak out and get to the tumor cells. You want appropriate leakage. If you have inappropriate leakage, think of it like a water hose. So if you have a normal water hose and you put water through, all of the water will come out at the end, which in this case is the center of the tumor. That would be a great thing. But if you have inappropriate leakage of the water hose, meaning you have holes all along your water hose, all that water is going to leak out before it ever reaches the destination at the end of the tube, which is what happens in your tumor blood vessels, right? So all of the drug leaks at the periphery of the tumor instead of making it all the way to the center because of these inappropriate holes in the blood vessels. And so actually reducing this permeability in the center is a good thing. And so we measure that, and we find that in mice that run, in those tumors, there's this reduction in the inappropriate permeability. And when we use chemotherapy and we measure how much chemotherapy gets into the tumor itself, we see that per dose of doxorubicin, so what you're measuring here is how much doxorubicin is in the tumor after one dose of doxorubicin. So mice that did not run here versus there's a significant increase in the amount of doxorubicin that got into the tumor itself if the mice have been running for the last 2 weeks. And so for us, that's really exciting because it suggests that exercise may be a way to improve the amount of drug per dose that gets into the tumor. But especially if you're a patient, you're thinking, but what about the terrible side effects? We don't want to increase delivery of drugs to other organs, right? And so, of course, we looked at that. So here's how much chemotherapy per dose got into the tumor, significantly more in mice that ran. It really was not different in the muscle or the lungs or the liver, and was a little bit reduced in the heart. And there's some really nice data from the Kleinerman lab that really looked at how exercise may be protective of toxicity to the heart for doxorubicin usage. And so if anyone has questions about why that is true, that it works in tumors and not anywhere else, I would be happy to talk about it. Feel free to interrupt or ask me at the end. But we think that's really exciting. And so in theory, more drug per dose in the tumor should mean smaller tumors. And so, of course, we looked at the tumor size. I'm just going to move where I have my picture of you guys so I can show you. And so we looked at it in pancreatic, melanoma, Ewing sarcoma. Let me help you read these graphs because you may not often read tumor volume in mice. So you're looking at the size of the tumor on this axis, so higher means bigger tumor, and across time. So this is after 21 days of treatment, for example. And so what you're looking at here is the control tumor size in green. After 21 days of growth, it's this big. Exercise alone really didn't do much to the tumor growth, at least in this model. We treated, because it's pancreatic cancer, they get gemcitabine. We treated with gemcitabine. It did inhibit tumor growth. But when you did gemcitabine plus 5 days a week of exercise, it was significantly more effective at inhibiting tumor growth. Similar findings here in melanoma for exercise plus doxorubicin, and similar findings here, exercise plus doxorubicin for Ewing sarcoma. So all of these were significantly more effective when you add the exercise to the doxorubicin. And we have now quite a bit more data that I chose not to show today because it's pretty molecular focused, but that really suggests that this is in fact because of the improved blood vessel function and because of the better drug delivery to the tumor itself. And so that's sort of my first take-home message, is that exercise seems to improve the blood vessels in the tumor, at least in mice, and seems to lead to better anti-tumor effect because of more drug getting into the tumor. So the next thing that you might be thinking is you've probably heard a lot lately about immunotherapy. There are a handful of clinical trials in osteosarcoma looking at various either immune cell therapies or immune cell modulating therapies. And the idea is that immune cells can have an anti-tumor effect. So one way that immune cells access tumor cells is through the blood vessels. So I just showed you that exercise made the blood vessels work better. So did that also change the immune cells? Okay, and so we're going to focus now on immune cells. And I looked for some great explanation that was simple about how immune cells kill cancer. It's very complicated. I just don't have time to explain it in this, but keep in mind, this is the immune cell, this is the cancer cell. Immune cells kill cancer cells, but they often need help, such as better access to the tumor. And so we have done several models now. I'm going to show you our pancreatic cancer model, but we have it in melanoma and other models. We basically implant the tumor wherever it would grow, so here in the pancreas. Once it's established, we again separate the mice into either treadmill exercise, 45 minutes a day, 5 days a week, at a moderate intensity, or just to hang out in their cages. And then after their last dose of exercise, for 2 weeks of exercise, we take out the tumor and we look at the immune cells. And so we think this is really exciting. So I don't know how much you know about immune cells, but CD8 T cells are sort of what would kill the tumor. And so when you look at the number of CD8 T cells inside the tumor from control mice or exercised mice, it's significantly higher in tumors from exercised mice. And we look at activated CD8 T cells, that is also significantly higher in tumors from exercised mice. And so we find that really exciting because it implies that exercise may be a useful tool, not just to enhance drug delivery, but also to enhance the access of immune cells to the tumor to allow them to then do their job. I showed that we have this decrease in CD4 T cells. CD4 T cells are really complex and have mixed roles depending on the tumor type. And so this is maybe a good thing in pancreatic cancer. We haven't looked in osteosarcoma. In the interest of time, what I will tell you is there's been a handful of studies now where exercise has been combined with various types of immunotherapy in mice. And about 50% of them showed exercise made the immunotherapy work better, and about 50% showed no difference. It's not really clear yet why sometimes it works and sometimes it doesn't, and it's an area of active research that my lab and others are pursuing. So in the last couple of minutes before we move on to Dr. Ness, I just wanted to say, we have thought about okay, so exercise is great for mice with cancer, but what about people? And so I've worked closely with an exercise physiologist and a huge team here at MD Anderson to do some exercise interventions for patients. The data we have so far is from patients with pancreatic cancer. I realize that is not as relevant for osteosarcoma, but that's the data we currently have, so I wanted to share it because I think it's very exciting. So what we did was an exercise intervention. So the pancreatic cancer is treated in some ways like osteosarcoma, where between diagnosis and surgery, you get this very intense chemotherapy, sometimes radiation, and then you go to surgery. And so during that time, we did this exercise intervention. So it was performed at home. It was unsupervised. We simply asked the patients perform 60 minutes per week of walking and 60 minutes per week of strength building. For those patients who weren't comfortable walking, we suggested arm biking or swimming. And we sent them with this video that showed sort of modifications of how you could do strength training with resistance bands. We had them fill out exercise logs, and they wore Fitbits so that we actually knew whether or not they did the exercise. And so we had them do this exercise, and then they went to surgery. And so the tumors came to me. So remember, in mice, these are pancreatic tumors in mice. You can see that the blood vessels shown in green go from these sort of like disconnected sprouts to these nice big open vessels. So now in the human samples, so these are tumors that came out at surgery. Now the blood vessels are shown in red, but again, sort of this change from in our control patients to our, we call it prehab exercise, you're prehabilitating for surgery. You now see this big open lumens in these tumors. So we can quantify that. So there is this increase in the number of blood vessels, the length of the blood vessels, and a non-significant trend towards more of these open lumens. And so why is that exciting? It's exciting because it means that what we found in mouse and mice appears to be true in at least these patients with pancreatic cancer. I would say it was a small study, it's preliminary, but I think it's exciting because it really suggests that exercise may change the blood vessels in the tumor of patients. We also did look at their CD8 T cells. So we found significantly more CD8 T cells in the tumors that came from patients who were in our exercise study compared to historical controls, and a trend towards more granzyme B expression. So granzyme B is important for whether the T cells are actually able to kill tumor cells. And so again, very small study, very preliminary, but we think exciting because it suggests that something as simple as exercise may change the biology of the tumor itself in a way that may be beneficial. So just in summary, we have used mouse models and done some clinical research that suggests that exercise really does have some very provocative effects on the tumor itself by changing the blood vessels and the immune cells. I didn't show you any work in other cell types, but really what my lab does is try to understand this at a molecular level so that we can make smart choices about how to combine exercise with other standard therapies for the treatment of cancer. And so with that, I'll just thank my team and say that none of this could be done just by me. It is an enormous team, both in the lab and in the clinic, and I'm grateful for all of it. I'm going to stop sharing, and I'd be happy to take questions now or go on to Dr. Ness and then come back later, whatever you guys want to do.
Oh, that's great. Thank you so much, Dr. Schadler. And maybe Dr. Ness, if you want to go ahead and get your slides up, and while you're doing that, I did have a question that is so, it's so great to actually see the data behind all of this. But one thing I am trying to reconcile, and it's more just because, we hear a lot about angiogenesis in tumors and how the growth of these new blood vessels can help feed the tumor. So I'm trying to reconcile that with everything that you've shown that shows that better, improved vascular function helps with drug delivery and increases the number of good immune cells. So I'm trying to, how do I reconcile those two things?
Yeah, it's a really good question. And okay, so a couple of things. So historically, tumors are usually hypoxic, meaning not enough oxygen because of these dysfunctional blood vessels. And historically, we thought, okay, so if we wipe out even more blood vessels, we'll create even more hypoxia, even less oxygen, and that will kill the tumor. What was found in clinical trials was that what actually happens is that the tumor has a brief period of stopping growth, but then becomes more aggressive because the cells are searching for oxygen, so they actually become more metastatic. So it turns out that actually this idea of starving the tumor is very briefly okay, but then often leads to more metastatic, more aggressive tumors because the tumor cells are now going to search for oxygen and nutrients. So that's one thing, is that this idea of stopping angiogenesis to starve the tumor is very complicated. That said, it's not always a bad thing, right? So, for example, there's a drug in clinical trials called cabozantinib. I may have just pronounced that wrong, but there's opening a trial for osteosarcoma. That drug will, it has what we call anti-angiogenic properties. But the difference is you're looking to improve the blood vessels, not delete the blood vessels, right? So if you use that drug at appropriate doses, you're very likely going to cause the blood vessels to stop hyperproliferating and instead become functional, which allows more drug access. So that's one thing, is that it's actually a little more complicated than we used to believe, that angiogenesis role in tumor growth. The other thing is that with exercise, we would never, ever recommend that you just exercise. We would always recommend that you exercise with whatever standard therapy your oncologist is suggesting, right? And so the idea would be that you're improving the delivery of the therapy. So when we do exercise without therapy, I've never seen it make a tumor grow more, but it usually does kind of just nothing. So I hope that was helpful.
Yes, thank you. All right, thank you. Great, Dr. Ness, if you want to go ahead and start with your slides. Oops, Dr. Ness, you're on mute still.
Great. Thank you. I'm going to talk about how exercise improves fitness and function both during and after therapy for pediatric sarcoma. here, we want to look at this slide first. So I just want to show you how the rate of malignant bone tumors and rhabdomyosarcoma is remaining pretty steady over time, but mortality is decreasing. So we have many more, what you call them, osteo warriors?
Right, osteo warriors.
Osteo warriors out there that we want to have not only quantity of life, but quality of life, quality of survival. And so as an epidemiologist, I think about data like this, but as a physical therapist, I really think about how people move and function every day, and it's really important to me. So pediatric sarcoma treatment requires the uses of high doses of alkylating agents and or anthracyclines and local control with surgery and or if you have Ewing sarcoma, high doses of radiation. And this places patients at risk for therapy-related complications, both during and after therapy. So though many studies have addressed medical complications, for patients who have sarcoma, function and fitness outcomes have in the past not really been well described because it's a rare disease. So my questions were, what do fitness outcomes, cardiopulmonary fitness and muscle strength, look like among survivors of sarcoma? And then are there association between anthracyclines, fitness and muscle strength among survivors of sarcoma? So the SAFE-2 lifetime cohort is a study that was designed to establish a lifetime cohort of childhood cancer survivors that to facilitate longitudinal clinical evaluation of health outcomes in survivors as they age. So to be in this study, there's about 6,000 people in this study right now so far, treated for childhood cancer at St. Jude Children's Research Hospital who survived more than 5 years after diagnosis for their primary cancer. And I think that if we look at if we look at the aims of this study, the most important one is to use these data to guide health screening and risk reducing interventions. So these are the data elements we collect in this study. It's a 3 to 5 day visit at St. Jude Children's Research Hospital, and our survivors, 5-year survivors, go through this entire battery of tests, including testing in the Human Performance Lab. And this is my lab. We opened in 2007. We have 9 full-time master's prepared exercise physiologists and 1 half-time physical therapist, who's our liaison to the rehab department where the interventions are delivered for the kids on therapy. We see 35 to 40 patients per week, 3 to 5 hours of testing and 2 to 3 appointments. This is for survivors, and the youngest is age 5, and the oldest survivor we have right now is in his 70s. You can see him on the television commercial if you'd like to. And the assessments include patients currently receiving therapy too, osteosarcoma, Ewing sarcoma, rhabdo, brain tumors, kids with leukemia, and long-term survivors. My staff also provide remotely delivered or Zoom supervised exercise sessions for patients and survivors. And currently we do 31 to 32 remote visits per week. These are intervention visits, in addition to our 35 to 40 assessments. And the goal of this was to be able to provide interventions to people who don't live in Memphis. Memphis isn't that easy to get to. Got to take 2 planes usually. Well, probably not from Texas, but you got to take 2 planes and you know, you got to take a cab, and you know, so we wanted to be able to deliver this intervention to people in their home environment, and especially for our college students who are on the call, we deliver this if you're in your dorm room, if you'd like, and that way you don't have to go be in front of everybody else if that's a thing you don't want people to see you do. So the evaluations we do, cardiopulmonary fitness, we also look at autonomic dysfunction. Sometimes after you've had anthracycline-based chemotherapy, you have some problems with heart rate variability and dizziness. We measure range of motion and flexibility, activities of daily living. And then we measure your body composition, anthropometrics, isokinetic and isometric strength, muscle quality. We do quantitative sensory testing. We measure neurological integrity, functional balance, and general mobility. We looked at the first group of osteo and Ewing sarcoma survivors who came in. 157 were bone tumor survivors, mostly osteo, and 49 soft tissue sarcomas. 39 had tumors in the upper and 167 in the lower extremity. Just over half were male. 17% were non-white, and these people were around age 13 at diagnosis. And again, they ranged in age in this study from 19 to 65 years of age. And then we had a 206 comparison group members, frequency matched on age, sex, and race. So these are healthy controls. And you can see that, nearly everybody had surgery. In the bone sarcomas, 61 had limb sparing surgery, but there was a large proportion of survivors because these were older survivors and technology wasn't as great back in the day. So limb sparing devices just weren't very well made for pediatrics back in the day. So there was quite a number of people who had amputation. Not very many got radiation, which is very uncommon. Osteosarcoma is not responsive to radiation. But many, almost all the osteosarcoma, bone sarcoma survivors got an anthracycline, an alkylating agent, and or platinum, which can make you dizzy. So you can see that 35% had low lean muscle mass. 12% of the bone sarcoma survivors had an ejection fraction. That's a measure of how hard your heart can pump, of less than 50%. 57% had difficulty with the diffusing capacity of the lung for oxygen. 28% had a sensory neuropathy. 24% had a motor neuropathy. So that means decreased feeling in hands or feet, a motor neuropathy, decreased, ability of the nerve to send you a signal. And that's these neuropathies were unrelated to having the limb sparing surgery. These were in the normal extremity. So, and then 79% had a musculoskeletal complication, and the median number of musculoskeletal complications, or I would call these additional surgeries, right, was 2. So you can see here, if we look at the percent with impaired performance with a z-score of less than -1.5. So the dotted line is what we would see in a regular population. So not everybody's strong or fit in the regular population, but the prevalence of loss of range of motion, poor balance, poor knee strength, poor ankle strength, poor aerobic fitness, and difficulty performing activities of daily living was much higher in survivors than in healthy controls. And I just wanted to show, because this was really what I was interested in when I looked at this study, was the association between doxorubicin, which is the anthracycline equivalent dose, and peak VO2. So for our athletes in here, you probably have had your peak VO2 tested. They put you on a treadmill or a bike or a hand bike and have you work until you're not wanting to work anymore. And we see how much oxygen in milliliters per your body weight per minute you consume. And this is a test of overall fitness. So you can see that the higher the dose of anthracyclines received, the lower the fitness. So in summary, cardiopulmonary fitness and muscle strength in survivors of pediatric sarcoma are impaired, and that cardiopulmonary fitness decreases with increasing anthracycline dose. So my question was, are there interventions that might improve strength and fitness in pediatric sarcoma survivors? So this was a very small pilot study that we did just to see if people could tolerate it. These are survivors of sarcoma. They did a 12-week exercise intervention, and they all had cardiomyopathy. So they already had a lowered ejection fraction. We wanted to see if it was safe. And we did aerobic exercise 3 to 5 times a week in 20 to 45 minute sessions. We always do our exercise sessions tailored to the person's fitness and ability so that we don't overwhelm people when we start exercising. Everybody can't go out and run a marathon in the general population. And sometimes people have difficulty getting out of bed. So, we might start there. Sometimes that's where we start. I can't get myself out of bed and across the room to the bathroom every day. That's where we start, if that's where we are. And then we did resistance training, and we did some compliance monitoring. And you can see that even in people with reduced ejection fraction, so people who already had been diagnosed with heart failure, and these people were on medication, we were able to improve their ejection fraction with an exercise program that was like this, as long as it's tailored and it accommodates all of the difficulties that they have. We improved their maximal oxygen consumption. We even reduced body fat and weight. Some people have difficulty with their body weight when they can't move, so they were able to lose a little weight. And these people were a median age of 38 years. So they're not young, but they were all treated when they were children. So in conclusion, these adult survivors of pediatric bone sarcoma with reduced cardiac function safely respond to an exercise intervention. So it's not dangerous to exercise. So from this study, we came up with this and some other studies, but we came up with a study to test the efficacy of a telehealth-based interventions to improve functional capacity as assessed by measures of exercise capacity, cardiac, pulmonary, musculoskeletal, and neurosensory function. So as a caveat, I applied for this grant prior to the pandemic when Zoom wasn't a thing. And we got funded in 2019, right before the pandemic. So it was opportune. And so what happens is the participant is a survivor of childhood cancer enrolled in the St. Jude Lifetime Cohort, and they have reduced cardiac function and reduced exercise capacity. They're not necessarily all osteosarcoma survivors, but they have an exposure that make them have peak oxygen consumption too low. And so they get an intervention. They do it for 20 weeks. It's delivered remotely. And we're looking at aerobic capacity and strength as our primary outcomes, but we're also measuring a lot of other stuff, but we measure everything remotely. Telehealth can be done. We measure all these things at home. You don't have to come in. Anyway, we've randomized 149 of our 160 people. We should be finishing up enrollment in February and finishing the study sometime this summer and have good results. We're also measuring changes in methylation profiles, which is, because I'm interested in accelerated aging, is a sign of accelerated aging. So we're looking at that too. So I just wanted to show you kind of what the telehealth looks like. This is Nicole.
Are you ready? Ready. 3, 2, 1, go. The next one that we have is the wall push-up. And I remember I was talking about the wall getting a little easy. So we talked about trying to move down to a counter or a table. Do you want to try a counter or a table today? I do. All right. And then Shane, I'm going to have you walk your feet back just a little bit more. Okay. All right. And then we're going to go down still in that straight line and back up. Okay. All right. You ready? Ready. We're going to try 15, okay? Sounds good. All right. Ready, set, go. 1.
That's fantastic.
Yeah, thanks. So you couldn't see her total knee. She had a total knee because she had pants on. But anyway, so my question was then, well, will this intervention work if we start earlier? And of course, you know, so we did a little pilot to see if it would work if we started earlier. And this was to determine if individuals diagnosed with a malignancy of the lower extremity could do a 10-week preoperative exercise intervention. So this was during the first part of therapy, during chemo, before local control, before surgery. We had 14 patients in our intervention group, and our 35 controls were from a historical cohort who were treated in the couple years before these 14, because I didn't want to exclude anybody who was currently getting treated from being able to participate in this intervention. So what we did is we did an initial evaluation, and then we did 10 weeks of preoperative PT, including strengthening, endurance, exercise, and stretching. Now, many institutions offer physical therapy to their patients with osteosarcoma, but there's a lot of coming and going between the hospital and the home, and the hospital and the housing. during the prehabilitation period. And so it's difficult to get people to have really a regular exercise session. And so what we did is we scheduled these people to stay in our housing. We have housing. We scheduled these people. This is before Zoom. I did this before the pandemic. We scheduled these people to stay in our housing and not return to their home community during the first 10 weeks while they were getting chemo so that we could capture them for physical therapy. And so 12 of the 14 patients completed at least 50% of the scheduled physical therapy appointments. You know, sometimes when you're getting chemo, physical therapy is not on your list of things to do that day. Although the patients call me no choice Joyce. So I come into the room and one of the patients told me, "Oh no, Mom, no choice Joyce is here." And my name is not Joyce, but I thought that was kind of funny. So that happened. And you can see that the functional mobility assessment is a specific assessment that was actually designed for kids with osteosarcoma. And you can see that, you know, we were able to improve their FMA score 10 to 12 weeks post-surgery. So pre-surgery, we kept them the same, right? But post-surgery, they had better outcome. So this, what we were looking for here, and it's a mobility test. It involves marching up and down stairs and with your crutches and your IV and everything, and going up and down the hall and looking at your heart rate. So we were able to improve that. So our potential new study, and this is to just follow along from what Keri said, because of the work that Keri's done for tumor control, and because of the work that I've done both essentially post-treatment, is we want to see if a remotely delivered prehab program. So you don't have to stay in St. Jude housing, because that is not any fun if you're 13, I'm sorry, on the tumor microenvironment in pediatric and adolescent and young adult patients with newly diagnosed sarcoma. And then also look at the impact of the exercise prior to local control on function and fitness, because we did a small pilot, but we don't have big data on this yet. And then evaluate the associations between improved function and fitness and the tumor microenvironment. So if we can improve fitness more, can we improve the tumor, and you know, can we optimize the tumor microenvironment so that that we actually facilitate cure? I think that that's important. That doesn't mean that my post-intervention work isn't still ongoing. We did this telehealth-based intervention. We've also done some diet stuff and specific resistance training for people who would prefer the Orange Theory model versus the general exercise model. I call it the Orange Theory model. It's where you do really high intensity work and a lot of strength training. So I can't list everybody who I have to thank. So mostly what I want to do is thank the St. Jude Lifetime Cohort participants and the patients at St. Jude for letting me intervene in their lives, and for being really great participants in my research, and for making my job the best job on the planet. And with that, finished right at 10:02, and I'm happy to take questions.
Perfect. You guys are extremely coordinated on the timing, and also both on the topics and just kind of the topics that you each covered. Walker and Vicky, I'm gonna actually open it up to you guys, and anyone in the audience, please feel free. I think actually we have one question that just came in. Do you guys want to tackle the question that came in, and then please feel free to follow up with any of your own?
Yeah, I can ask the question that just came in. So somebody asked, do either of you have any input on the effect of exercise on radiated tissues, specifically in joints?
You want me to answer that, Keri? Okay. Well, so yeah, so we exercise people who have irradiated joints. Obviously, we do a careful assessment of the joint integrity before we begin the exercise. We can actually do that over telehealth. We can take a good look at the range of motion and you know how much scar tissue there is, and then we adapt the exercise to accommodate that. We also will help people with scar tissue and fibrous tissue management techniques, some deep tissue work, and some what I would consider alternative medicine methods.
Just another personal question. I was wondering, how do you go through, I guess, rehabilitation and other exercises when you have like vast muscle differences? If you have a lot of muscle removed on one side rather than the other, but you still want to utilize the muscle on that side?
So what we would do is we would, adapt the exercise specifically for the loss of muscle on one side of the body. And for aerobic training, for somebody who has like a pelvic or a lower extremity injury that makes it really uncomfortable to exercise on your feet, we come up with strategies like modifying a bicycle seat so that you can cycle if you have full range of motion in your ankle and knee. We've done that for survivors. Or upper extremity exercises are actually harder than lower extremity exercises. So arm exercises get your heart rate up much faster than leg exercises. We have a ramp test that we do with just a cane that we do at home to test upper extremity, to test the heart with upper extremity exercises. I also recommend for people who have muscle imbalance that if they're not opposed to water, that if they have access to a swimming pool, that's the best place to exercise. Either do water walking, or if you know how to swim, because that is actually a whole body exercise all the time. And even if you don't want to use the muscle on the side where it's weak, or if that side of the body doesn't want to use the muscle, when you swim, you just don't have any choice and your muscle will follow along. We also have all sorts of fancy running devices now called an Ultra-G, which is a suspension system that you can actually run even if you don't have good stability in your hip or pelvis.
Are those like where they have like a bunch of air that
Yep.
like comes into the? I always want to try one of those. Can people run even if they like have had some muscle removed and they can't fully utilize it?
Yeah. In the Ultra-G, yeah, it's easy to run in the Ultra-G. We even run people in a suspension harness in the parallel bars without the Ultra-G if we can get the padding right. We just, depends. But yeah, the Ultra-G is a magic little treadmill device. If you want to send me an email after this and tell me where you live, I can find a clinic that has an Ultra-G.
I'll ask Christina. I've always wanted to try one of those. Like, I just can't wait to run again. One day I just want to like wake up and be able to run.
Well,
That'd be a dream.
you can run in the pool if you have access to a pool.
Yeah.
If you're in college, they probably have a nice pool. I swim at the community center where there's Band-Aids on the bottom of the pool, but you want to pick a clean pool. I don't know. I'm sorry.
Walker.
Yeah, I have one question. So I was curious, is there a point of like diminishing return when it comes to doing like the pre-operational exercise? Because I know like if you would say you can go like do as much intensity and volume as you want and like it'll continually get better, I would have been on the treadmill like till I dropped every day. But at the same time, if there's like a point where it's not going to do you any good, like do you know where that is?
Sure. So you're an athlete, right? And so when you were training for any athletic endeavor, there's a certain amount of training that your coach came up with that was appropriate for you at that time point. They didn't say go out and run a marathon every day. So rest and recovery is important. Also, you have to take into account the fact that the way that muscles work is you stress them and then you let them rest so they can adapt. And that's how they get better. And so for each person, that's going to be different because it depends on where you start. So, if you start out, if you're a high level athlete and you start out during treatment for osteosarcoma, well, the first thing is going to happen is you're going to feel super crappy compared to how you felt before because you're used to being super fit. And so we would assess your strength and we would start exercising you just like you were an athlete. We exercise our patients as if they are athletes, always. Remembering that if you're getting chemotherapy, your heart rate response is going to be fast. Your heart rate kind of gets up and up and up during chemotherapy. So it's sort of that's what we do. But no, I wouldn't recommend running on the treadmill until you drop. It would be individualized. But for instance, since you were an athlete prior, it probably would be higher levels for you than it would be for somebody who'd been sedentary.
That makes sense. Thank you.
Walker, I can answer the question about the person who said they couldn't. I was lucky if I could lift up my head off the pillow. Well, I would be no choice, Joyce, and you would be getting out of bed. That would be the first thing we would do, and we would monitor your heart rate, while you got your head off the pillow. Might just be sitting up in bed. We always start where the patient's at. That's where we always start. And some days are a bad day. And remember that osteosarcoma is very common in teenagers. And so teenagers they're in transition in their life. And so there's some psychological overlay from being a teenager and not wanting to be told what to do, because it's just the transition you are in your life. When my teenager was a teenager, I got a lot of eye roll. And that doesn't, just because somebody has cancer doesn't mean that they don't have the ability to give you eye roll when you ask them to do something. So that you got to start where people are at.
There should be a study correlation of like osteosarcoma and enhanced eye roll. There might be actually a positive correlation there.
I have one question about someone who is 2 years out and has drop foot from a limb salvage after removal of the calf muscle and fibula in the right leg. And they were kind of wondering, how would you recommend finding either virtual local program just in this specific situation to help increase stamina, flexibility, and muscle balance?
Send me an email at kiri.ness@stjude.org. I will, and tell me where you live. I can send an email out to a listserv that I'm a member of. That's like all the PTs that do sarcoma.
Thank you, Dr. Ness. And since you offered that up, I will note that we can include for everyone attending, we'll include that information in a follow-up email that you get. So we'll make sure you can access that.
The last question, there's a patient that has 2 necrotic upper humeruses and needs 2 shoulder replacements. The surgeon thinks this is a result of the original chemotherapy having reduced the blood supply to his bones, causing them to die. Have you seen similar issues in other patients?
Yes, we see that not so often in osteosarcoma survivors, but it's from steroids. And that it happens, and especially in leukemia, it's fairly common for people to get osteonecrosis or, dying back of the bone from some of their chemotherapy, and they have to have a joint replacement, or there's a couple other procedures that they sometimes do. Core decompression, it's called.
So Dr. Ness, it could be the steroids, because I know often in osteosarcoma treatment, the patients do take steroids to combat some of the other side effects from some of the other drugs. So you think it's
usually nausea. Yeah, but now she said that he took no steroids. So yeah, I mean, it could be one of the other chemotherapy agents.
Okay, well, we are just at the top of the hour already. It went by quickly because fascinating topic. Thank you so much, Dr. Schadler and Dr. Ness, for joining us on OsteoBytes today and for making it better for pediatric sarcoma patients. More information on this and all OsteoBytes can be found on the MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And next week, look for a new episode of our Osteo AYA podcast. It's going to drop on Thursday, January 18th. Vicki actually joins Camille and Mia to discuss making friends after a cancer diagnosis. And then we'll be back with OsteoBytes on January 25th, when we are going to be joined by Dr. Andy Livingston, also from MD Anderson Cancer Center. And Dr. Livingston will discuss the background and scientific rationale for combining immunotherapy with cabozantinib in teens and young adults with osteosarcoma, and provide information about the ongoing TACO study, which stands for atezolizumab and cabozantinib, for the treatment of adolescents and young adults with recurrent or metastatic osteosarcoma. Dr. Livingston definitely knows how to come up with a good trial acronym. You can find our OsteoBytes lineup for the next few months on our website. And if you have any ideas for future topics you'd like to hear about, please share them with us at events@mibagents.org. Thank you so much, Dr. Schadler and Dr. Ness, for helping us kick off season 5 of Osteobites. And also Walker and Vicki, always a pleasure to have you, and all of you for spending an hour with us today. We hope to see you back here on Osteobites in a couple weeks on January 25th when we talk to Dr. Livingston. Thank you, everyone. Have a good rest of the day.